Hello friends, Tembigla again. Today we are taking dermatomes, myotomes and peripheral nerves. As we're going through some pictures so that you can see what are we looking at. What are the dermatomes? Since we all know that we've got a central nervous system and the peripheral nervous system. Central nervous system is made up of brain and spinal cord and is connected to the periphery via the peripheral nervous system. Peripheral nervous system are these different nerves that connects the periphery to the central nervous system. We have 31 pairs of peripheral nerves, of different nerves, starting from cervical, thoracic, lumbar, sacral, and one pair of coccygeal nerve. So that is the way dermatomes are. Let's just have a picture. Continue to look at this picture here. This one you can see when you look at the skin. That is dermatomes. The dermatomes you can test them by doing sensation test, but you need to have a picture of where to test and what to test. If you are looking posteriorly, let's say your patient is lying prone on the plinth. If the patient is lying prone facing down, then if you see this point, that is a point where the external occipital protuberance is, then above that point covering the head, the sensation test you can do there is for C2. The sensation test you can see there is for C2, only posteriorly. Then if you look in front, the face is not cervical dermatomes. The face is trigeminal nerve, or is cranial nerve number 5. They divide that nerve into V1 on the forehead, V2 around the nasal area, and V3 below. So the face is trigeminal nerve, you can test. Then when you look at the neck posteriorly, neck you can divide it into 3. You can test the sensation of C3, C4, and C5. Right? If you look posteriorly, you can test C3, C4, and C5 in terms of sensation. The way that I do the neck, I divide the neck into 3, and the posterior part of the head I know is C2. And then in front, the face I know is trigeminal nerve. Then when I look posteriorly, is C3, C4, C5 along the neck. Only those 3 dermatomes you can test it there. Then if I come for 6, 7, and 8, I go to the hands. Neck is C3, C4, C5. I go to the hand. If you look at the hand, then the hand is 6, the thumb is 6, and then the second finger and the third finger is 7, and the fourth and the fifth finger is C8. Then you can continue along the arm like that up until you come to this area. Like I can say at the area of armpit. Check the armpit and then you go up there. Then that's where you test C6, 7, and 8. But to get it right, test the thumb for C6 and test finger 2 and 3 for C7 and finger 4 and 5 for C8. That is posteriorly. Right. And then you divide the thoracic vertebra into 12. You divide the thoracic vertebra into 12. Right? That you test T1 up to T12. And then below there, that will be L1 to L5 posteriorly. But L1 to L5, I like to test it anteriorly. Even if you look anteriorly, mainly the abdomen and the chest anteriorly, it doesn't look the same like posteriorly. Posteriorly is divided into the part of cervical vertebra 6, 7, and 8, and then along the thoracic is thoracic, along the lumbar is lumbar. But in front is only thoracic. You can see is T1 up to T12. So the front you divide it from T1 to T12. And then the lumbar L1 is area of the groin. You can test sensation for L1, the area of the groin. Below there, diagonally, is L2. And below there, also diagonally, is L3. And then across the knee, it's L4. Then below there is L5. So what I can say, for you not to forget this, anteriorly, when you look anteriorly, the trunk anteriorly, you can only test the thoracic dermatomes. And then the lower limb anteriorly, mainly anteriorly, you can only test the lumbar. Only at the lateral side, you can test the C1. Or if you turn your patient to prone, you can barely see S1 and S2. Then the S3 and S4 is around the anal area. That is S3, S4, and S5. Let's start it all over again. If your patient is lying prone, the head you can only test C2. In terms of dermatomes, there is nowhere where you can test C1. You can only test C2. The neck you can test 3 dermatomes, C3, C4, and C5. And then I advise people when they test C6 and C7 and C8 to use the hand. The thumb is C6, finger 2 and 3 is C7, finger 4 and 5 is C8. And then if you continue posteriorly, the area of the thorax remains for the thorax. You divide the dermatomes for the thorax. The area for the lumbar, you divide the area for the lumbar. And then the area of the buttocks is for the sacral. I mean, it's for the sacral. It's S1, S2. But S1 and S2 comes down posteriorly. But S3 and S4 and S5 is around the the anal area, is around the anal area. But if you look in front, if your patient is lying supine, if your patient is lying supine, the neck you can still test C2, C3, and C4, and then C5, C4 to C5, yes. And then C6, you use the same principle. C6 is your thumb, C7 is your second and third finger, C8 is your fourth and the fifth finger. And then the anterior part of the trunk, you divide it for the thoracic vertebra. This is very, very, very important, especially when you determine the level of, when you are treating the spinal cord injury patient, you need to determine the level of the lesion. So this knowledge is very important for you to be able to understand exactly where the spinal cord injury is. You need to test these level. You need to follow the dermatomes. So that you will know that if the injury is complete, incomplete, or is only affecting the posterior part or the anterior part. And then you can only determine that if you follow these dermatomes. As I said, when you continue to look in front, the trunk in front is only thoracic, T1 to T12. And then lower limbs in front is mainly lumbar. You divide them for lumbar, but you divide them diagonally. This area of your groin is L1. Below that is L2. Below that is L3. Below that is L4. Below that is L5. Then laterally is part of S1. Or you can test sacral one from the posterior part. Around the area of your glutes, S1 and S2, they all come down. The lower limb posterior, you can divide it into S1, S2. Then S3 is around the anal opening, and S4 is around the anal opening, and S5 is right at the area of the anal. I think we are all together. We are still all together. Okay, let's go for myotomes. Let's come for myotomes. Dermatomes are sensory nerves that you are testing. Whether your nerves can feel when you touch, when you pinprick, when you apply pressure. You need to test all those things. Then you will know, you will follow your dermatomes. Right? That is dermatomes. Now for myotomes, you test motor function of these nerves. When we speak about dermatomes, the injury is normally around this area close to the spinal cord. Because remember, if you go far away from the spinal cord, these nerves will be intertwined to make cervical plexus. Down there, they will make brachial plexus. In the lumbar, they will make lumbar plexus. In sacral, they will make sacral plexus. And from the plexus, you get the peripheral nerves that are not under the dermatomes. We're going to do that. We're going to follow that last part. But the dermatomes, you follow. If there is a problem with the dermatome, your understanding must let you know that the problem is mainly in this area, is a specific problem in this area. Let's say, for instance, we have a problem of disc herniation posterolateral of L4 disc herniation. And remember, if when you test, let's say you test sensation and you see that sensation of L5, there is problem with sensation of L5, you must know if there is disc herniation, it can be it can be the L5 disc, because look at this picture. This is L4, this is L4 disc. Look at it. This is L4, but the L4 nerve is situated above L4. So disc herniation of L4 will normally affect L5. So now I want you to, when you make your diagnosis or your clinical reasoning, don't say when the patient present with the signs and symptoms of disc herniation, and then you see that the muscle that are supplied by L5 are weak, and then the dermatome of L5 is weak, don't jump and say L5 disc is the problem, because L5 is there. L5 cannot affect intervertebral disc. L5 disc cannot affect L5 nerve. It's impossible. L5 nerve is affected by L4 intervertebral disc. Most of the students, they miss this. Even clinicians, they miss this. When they test a patient and then they figure out that, okay, this patient has got L5 problem, they will jump and say their diagnosis will be, or their hypothesis will be, L5 intervertebral disc. They don't have a picture that L5 cannot compress L5 nerve. L5 intervertebral disc cannot compress L5. L5 can compress, L4 can compress L5. L5 intervertebral disc can compress S1. Or maybe if it is more centrally, it will make cauda equina presentation. Like even here, if it's more centrally, it will make cauda equina presentation. But we will deal with that when we do the intervertebral, when we do the vertebral column or low back pain and all other things. But now we are just following the dermatomes and myotomes. Okay. So I say, when you think about the nerve root, the problem is closer, is right there at the vertebra, is right there. The problem will be there. It's not normally away, because away, only the neurodynamic test will find a problem away from the vertebral column. Then that one we will discuss later in this video when we speak about the peripheral nerves, not dermatomes and myotomes. But for now, we are dealing with myotomes. The nerves before they mix other nerves and become different nerves. It's just before, you see. This is C1. Okay, now let's deal with myotomes. Okay, if you want to test the integrity of C1 in terms of muscle strength, you need to test upper cervical flexion, not cervical flexion, not the whole cervical flexion, upper cervical flexion, like tucking in the chest, the chin, tuck the chin in, right? And the muscle that you are actually testing there are deep neck flexors. That is for when you test C1. When you test C2, you test upper cervical extension. The upper cervical extension, you test the deep neck extensors. I think I have to mention some few maybe so that you have a picture of what I'm talking about. The deep neck extensors are small muscle deep in there, and especially when you have problem with those muscle, when they are tight or something is wrong with those muscle, they will cause a headache, because these first three nerves, we will explain when we do headache, are connected to a nucleus that is, okay, let's leave it there, let's leave that part there. But any problem of C1, C2, C3 will normally cause headache. We'll explain it later how it causes headache. But when you test C2 is upper cervical extension. C3 is side flexion, is cervical side flexion, right? You test side flexion. If there is weakness, and then you, if there is weakness, you will understand that the C3 nerve root is affected. If there is weakness in upper cervical extension, you will think about C2 nerve root being affected. If there is problem with C1, weakness in upper cervical flexion, you think about C1 nerve root being affected. Okay, C4, you test shoulder girdle elevation. You resist shoulder girdle elevation. If there is weakness there, you will query or you will question the C4 nerve root. If, let's say, dermatome 4, there is no sensation when you compare left to right, there is difference in sensation, decreased sensation, or no sensation, or just no sensation or decreased sensation. And then when you test the shoulder elevation, also there is weakness there, then you can question the integrity of nerve root C4. When you do your neurological examination, you can't conclude from one test. If, let's say, there is the patient doesn't feel well there and then the muscle is not affected, at least there must be some other evidence that this nerve root is affected, because normally the compression of this nerve root, normally it affects sensory and motor, because normally where the compression is already a mixed nerve, because posteriorly, close to the spinal cord, posteriorly is where the sensory root is, and in front is motor, but immediately they come together to make the spinal nerve. But the compression is normally around the area of the spinal nerve, of which is mixed nerve. So if it's compressed around that point where is exiting out of the spinal cord, it will affect sensory and motor together. So when you test sensation, there will be problem with sensation. There will also be a little bit of weakness when you test the muscle strength. So C4, shoulder girdle elevation. Then that we are all dealing with myotones, testing the strength of your muscle. And then C5, you test shoulder abduction. You test deltoid shoulder abduction. That is for C5. For C6, you need to test the biceps elbow flexion for C6. Again, you always compare. When there is a problem with sensation of C6 in terms of dermatomes, then you also test the strength of biceps by resisting elbow flexion. So if elbow flexion, patient has got a problem with elbow flexion, also when you tested the dermatomes of C6, and then you see there is impaired sensation, then you can query the integrity of nerve root 6. C7, you need to test elbow extension. C7, you need to test elbow extension. That is, you test triceps, the strength of your triceps. If there is problem with the strength of your triceps and also the dermatome of C7 is a problem, then you question the integrity of nerve root 7. C8. C8, you test C8, you test thumb extension and finger flexion. That you test this kind of movement. That is thumb extension. This is thumb extension. And then this is finger. This is finger flexion. The patient should be able to keep to make this for C8. Right? And then for T1 is finger abduction, adduction, finger abduction, adduction. If the patient is struggling, when you give resistance to this kind of movement, you give resistance to adduction or to abduction, there is a problem with abduction and adduction, then you can query the integrity of nerve root T1. Okay, let's recap a little bit. Let's start from up there again. C1, that is upper cervical flexion, tucking in your chest tuck in your chest, that is upper cervical flexion. C2, upper cervical extension. C3, side flexion. C4, shoulder girdle elevation. C5, shoulder abduction, that is deltoid. C6, elbow flexion, that is biceps brachiomuscle. C7, elbow extension, that is triceps. These two, C6 and C7, if you question something for C6 and C7, you can also test the reflexes of these muscles using your patella hammer, and you tap the tendon of the biceps. You can also tap the tendon of triceps. You can also tap the tendon of brachioradialis. When you see there is problem with C6 and C7, just to compare. C8, as I said, C8 is thumb extension and finger flexion. T1 is abduction, finger abduction and adduction. Okay. T2, T3, T4, T5, T6, T7, T8, T9, T10, T11, T12, and L1. There is no specific muscle you can test for these. And there is no reflexes you can test for T2 up to L1. T2 up to L1. Okay, L2. L2, you can test hip flexion, the strength of the muscle that causes hip flexion. Hip flexion is caused by iliopsoas. Psoas major, psoas muscle, and iliacus muscle, that is L2. Test the strength of those muscles and compare with the dermatome of L2. If there is no problem, then you check the following one. Then L3, you test knee extension. You resist knee extension. Knee extension is caused by quadricep. Therefore, you test the quadricep. That is vastus medialis, vastus lateralis, vastus intermedius, and rectus femoris for L3. You can also do the patella tendon there. You can tap the patella and check if is there any problem, is there any manifestation that you can trigger. Then L4, you test dorsiflexion of the foot. L5, then you test extension of the big toe. That is, you test the extensor hallucis longus muscle. The extensor hallucis longus muscle. If there is weakness there, and then also there is problem with dermatomes, then you can query the integrity of the nerve root of L5. Right. S1, you test eversion of the foot. Eversion of the foot. That is L5. That is S1. S2, you test, you let the patient stand on his toes. If he struggles to stand on his toes, then you will query the strength of the muscle that are supposed to help the patient to stand on his toes. That is the test for S2. Right? S3 and S4, you test the pelvic floor muscle. You check whether the patient has got a problem with bladder or genital function. If the patient has got a problem with incontinence or is got weak pelvic floor muscle, then which means the problem is S3 and S4. S5 and S6, S5 and coccygeal nerve, you can't do any dermatomes for the last two. Okay, I think we are still